Thank you, Atma, for those kind words. And without wasting much time, we'll straight away go to the artifacts in EEG. Most of you have seen the EEGs now, and some artifacts most of you are able to diagnose also and see this is an artifact. So, what exactly is an artifact? Is an EEG refers to any electrical signal which is not generated by the brain itself. It's from the outside source. So, when do you suspect an artifact? Restricted activity to only one channel. It's an artifact ultimately proven otherwise. It appears in more than one non-contiguous head region, suggests a discontinuous generator such as an artifact. Complex waveforms with alternating double and triple phase reversal. So that means it is not from the brain itself. And that appears at the end of the chain, electrode chain. That also can be an artifact, may imply a source distant to the brain. Then you have atypical generalized waveforms, which suggest a potential equipment artifact which can involve all the channels. Periodic patterns with a precise periodicity and morphology suggest an artifact. Precise morphology and periodicity. So in a artifact, in a discharge which comes at a periodic interval will not be same in every discharge. And then you have a very high or a very slow frequency, less than 1 Hz or more than 70 Hz. So, whereas most of the brain activity comes at the range of 1 to 35. And most important, it should not have a physiological field. So, it should be out of the field phenomena. So, what are the common sources of artifacts? What you see? Physiological, which is quite common because in the EEGs what we have seen now, normal eye movement artifacts, cardiac, myogenic, bone defects, mastication and deglutition, and abnormal movement like tremor, myoclonus, or other movements. Then you have non-physiological sources like electrodes, which are used to record the activity. You can have a pop, impedance mismatch, lead wires, machines and connections, which can have a aliasing phenomena or a jackbox defect, 50 Hz artifact, static electricity artifact, and implanted electrical like a pacemaker can cause an artifact. So what are the physiological artifacts do you see? Biological, muscle artifacts, ocular and cardiac. Muscle, most common is surface electromyography artifact. Then you have glossokinetic, which sir has already covered, and photomyogenic. Muscle is the most common form of bioelectric artifact, causes short duration potentials that occur in clusters or periodic runs. It's quite high in amplitude and frequency, most commonly from the frontalis, temporalis, and the masseter. Hence, it is seen in the anterior or the lateral temporal area. Single motor units are recorded from any of the electrode placed over on the scalp muscles, and you have repetitive negative or a positive deflection that can have a comb-like or a dirty picture-like presentation. Should not be reproduced at the adjoining electrodes. So only at that electrode or those areas which are having that muscle groups, you should have that abnormality. And frontalis EMG, mostly over the frontal electrodes when the patients are tightly close the eyes, and it can elicit a photic stimulation also, which can cause a photomyogenic artifact or a response. Temporalis EMG recorded from the temporal electrodes when the patient tightly close the jaws or make chewing movements. You can have these movements at the time of seizures also with oral automatisms, or any orofacial dyskinesis can cause these temporalis artifacts. So in this we see we have eyes are open and you can see a dirty line over the anterior frontalis on both the sides. So this is a classical muscle artifact, myogenic artifact. This occurring on the right side on the anterior as well as on the lateral leads. So if you see, now this is diffuse, occurring more on the left side. However, we can see over the frontalis as well as on the temporalis muscles also. So these are the artifacts, classical muscle artifacts, what you see in the EEG. Now again, eyes are closed and the patient is seems to be quite tensed maybe, and we can see it is over the anterior FP1, F3, F3, C3, and same over the FP2 and F4. However, the patient has tightly closed the jaws also, as we see the lateral leads also showing a similar fast activity, which is more than 50 hertz or in that range. Now, when we increase the paper speed, we can see we have made this paper speed as 2 seconds. So if you count this full 1 second, it is 50 hertz. So indicating it's more than the activity what you can get from the brain. You can get from the brain, but it's outside that range. So these artifacts can be reduced by reassuring the patient, comforting the patient, and massaging the particular muscle groups which are tight and patient has held them. However, in ICUs, these things sometimes are not possible because you can get a lot of these artifacts in confused patients, demented patients. Glossokinetic artifact, tip of the tongue is negative in polarity with respect to its base. And you have potentials being generated which are actually recorded slow movement from the frontal electrodes. You can have a slow wave, delta range, or slow activity with superimposed faster frequency. Now, this is the classical glossokinetic potential, and it is a polymorphic rhythm which you are seeing over the anterior leads, and the patient is using the tongue in speaking la la la, so you can record that activity over the anterior leads, and you can see it's a polymorphic anterior frontal rhythm which is more in the delta frequency. So as soon as the patient ends speaking or using the tongue, you can see immediately the activity is totally suppressed. A similar rhythm over the anterior. So this can be highly rhythmic on tongue tremor, or when you are nursing an infant, sometimes you can have a patting infant also, or you're feeding the infant. Monitoring the activity, electrodes at the cheek or the submental muscles activity, you can have a recording on those muscle groups, and you can see you can have more high amplitude activity than at the scalp from these muscle groups. And it is usually time locked to the speech. Swallowing and talking, these can also can cause EMG artifacts from the pharyngeal muscles because tongue is acting as a dipole. Photomyogenic artifact, which sir has already covered. Contraction of the anterior muscles of the scalp produce EMG artifact that vary from single or a sustained myogenic potentials. Contractions are usually time locked to the photic stimulation, begin and cease commensurate with the flash. So it's only seen on the anterior frontal leads. Usually seen at low frequency, at a frequency of 12 to 18 hertz, and it disappears when the interval between the stimulus shorter than the eyelid reflex latency. It's a normal response sometimes associated with hyperautonomic states or with increased muscle tones. So as soon as the patient has opened the eyes, we can see there is a myogenic artifact occurring over the anterior leads, and as soon as the patient has closed the eyes, it has subsided, indicating a photomyogenic along with photic stimulation at 18 hertz. Happening at 22 hertz also, similar finding. On opening the eyes, we are having a myogenic artifact, and on closing the eyes, this is disappearing. At 18 hertz again, we are having a similar finding. Now, coming to the next artifact, which is ocular artifacts. The most common is blink artifact, what we have seen most of the EEGs being discussed earlier. Then you can have ocular flutter, lateral gaze, roving eye movements, lateral actor spike, and ERG. Now, eye movement artifacts are mostly frontal distribution. They are usually symmetrical, classical characteristic shape is there, and amplitude of vertical eye movements never increases in posterior located channel. It's only anterior channels which are involved, mostly frontal only. Now, eye blink artifact, eye is a dipole. cornea is positive, retina is negative, and then you can have, that means that you have a dipole in the eye itself. So it's electrical potential produced by the movement of the eye. So as this shows, retina is negative and you have a cornea which is positive. Now when you close the eyes, you have a Bell's phenomenon. Most of you are neurologists, I need not tell that. So when the eye will go up, you have a positive phenomena which makes it double positive, or that is more positive. So you have a downward deflection with a positive phenomena. So it is usually bifrontal, synchronous, slow wave. Field does not extend beyond the frontal regions. So when you have a positive to negative, the eye should go down. So as the cornea moves up because of the Bell's phenomena, you have a positive which makes the pen go down. So this is what you see in eye closure. So, and now as soon as the patient is opened, again there is eye closure which is positive, followed by again a negative when the eye is opened up. So again eyes opened, which is a negative phenomena, then eyes closed, that's a positive phenomena. Repetitive eye blink, sometimes it can cause rhythmic slow waves, may resemble intermittent rhythmic delta activities, delta waves. Sometimes more rapid blinking can resemble a theta rhythm. It should not be mistaken for any abnormal epileptiform activity. It is identified by ocular monitoring and disappears on eyes being closed. So this is eye flutter which is happening at a very fast pace. In a second we are having around 3 eye closures, so indicating eyelid flutter. So then you have rhythmic activity, that is eyelid flutter, 5 to 8 hertz, consists of low voltage slowing, often rated over FP1 and FP2. This is quite slow. In a second, we can see eyelid flutter happening over the anterior lids, 3 to 4 hertz at the max, and it is polymorphic rhythm, not a monomorphic rhythm. Again, eyelid flutter over the anterior lids, localized only to the frontal channels. Now, lateral rectus, which I think Neeraj has already discussed, you can have a sharp positive deflection of short duration with a slow fall of the as the muscle relaxes, recorded from the F7 and F8, that is left and the right components. Positive components most commonly seen, mimics a calibration signal sometimes. Now they are easily recognized because they create a phase reversal in the anterior temporal deviations that are of opposite polarity on opposite side of the scalp EEG. Greater positivity on the side to which the gaze is directed and negativity on the opposite side. So as this image shows, you are actually to the left, so F7, and this becomes more positive, and then you have a phenomena, that is the window is opening on the left side, however closing on the right side. So in this, if you see FP7, F7T3, we can see there is a window opening on this side and it is closing on the opposite side. So indicating the patient looking on the left, and then he again turns to the right. So it's roving eye movements to both the sides. Now eye moves to the left, yielding a positive phase reversal in F7 due to cornea polarity, and F8 electrode demonstrates a negative phase reversal from the retina itself. So a similar phenomena in another EEG, we can see eye to the left and then again goes to the right, then again to the left and to the right. So it's eye window opening and window closing phenomenon, either of the eyes. Then you have roving eye movements, which is seen during drowsiness, frequencies less than 1 hertz, resembles unstable baseline rhythm. So they are usually slow movements. If you see, so in this we can see these two channels are coming close and this is going apart, and then you have a phenomena which is, so this possibly it is to the this side, the patient is moving on the left, then right showing a negative polarity. So it indicates It's very slow, not more than 1 hertz. Direction of eyes is toward the side where the deflections are out of phase or where the pens separate out. That is positive phenomena. Similar finding in another EEG, another slow roaming movements occurring on the right side, left and the right side. We can see the pens are going apart and here it's going together. Coming to the ERG, it's a normal response of the retina to the photic stimulation. Amplitude is usually low, appears in anterior head regions, confused with abnormal frontal sharp waves, usually obscured by normal EEG activity, especially during recording of electrocerebral inactivity. Retinal response can be seen during photic stimulation. So this is photic at 1, 2, 3 hertz, and we can see anterior frontal lead showing a 3 hertz response. And this has been confirmed by EOG also in this patient. There is an EOG also put in this on both the sides, right and left. We can see a similar waveform recorded from the EOG also. It indicates a ERG finding. So eye movement detected using a single channel connecting the right lateral upper eyebrow and the left lower lateral eyebrow. Vertical eye movements, you have bilateral infraorbital electrodes referred to the ipsilateral ear as a reference, and it represent the eye as a dipole and demonstrate phase reversal, which are out of phase with cerebral activity when due to eye movements. So how do you correct these eye movement artifacts? Disappears when the patient keeps the eyes closed and is still. Patient may be told to place the fingertips on the eyes. If eye movements cannot be stopped, monitor by electrodes placed near the eyes, which actually can demonstrate simultaneous display and comparison. That is, distinction between the eye movement artifact and the frontal slow waves can be demonstrated. Now, asymmetric eye movements artifact, decreased movement of one eye, asymmetrical placement of the electrodes, unilateral enucleation or prosthetic eye replacement, external ophthalmoplegia along with or Bell's palsy can cause all these asymmetric eye movement artifacts, or it can be a skull defect with eye movement artifact will be lower in amplitude if led to the skull defect. Now in this we can see only one side we are having unilateral eye blinks, right one is not showing any eye blink movement or artifact. Coming to the cardiac artifact, electrocardiographic, EKG or ECG, ballistocardiographic, pacemaker and pulse artifacts. Now EKG artifacts may appear simultaneously with prominent QRS complexes seen in several channels, seen in obese patients, short necks and infants, most often detected by referential montages using ear electrode as the reference, and it is seen more over the posterior head regions. Recognized easily with rhythmicity and regularity, coincidence with the ECG tracing, but it can pose a problem when you have a EKG which is not regular or it is intermixed with two spikes. Sometimes that can cause confusions. So in this, if you see posterior left P3O1 and left T5, we can see small spikes along with EKG. They are time locked and to the EKG. So again EKG artifact, we can see T6O2, T3, T5. So it is almost generalized but more over the posterior head regions. It can be reduced by changing the head position related to the position of thorax. Ballistocardiograph effect, they are actually the potentials which are movement artifact, that is time locked to the EKG, microscopic movements of electrodes and wires from the recoil effect of beating heart produce rhythmic activity of low amplitude. Cardiac monitoring will show the relationship of cardiac signal to these pulsations, but they are not always time locked. Pacemaker artifacts is high voltage short duration spike activity that precedes the usual cardiac signal, may be continuous or intermittent depending on the type of pacemaker which the patient is having. So this is pacemaker artifact. It's A1 and A2 referential electrodes, and we can see it's a generalized spiking wave discharges. Pulse artifacts, usually seen in a single channel as a periodic slow wave. Electrode is placed over the surface artery. Prominent when electrode is loosely placed, there is a 1-to-1 relationship to the EKG and the field is to a single electrode. Lags the QRS complex of ECG by almost 200 to 300 milliseconds. So in this, if you see, this is the EKG, and along with the EKG, we can see almost 200 milliseconds there is a slow wave which is following after every beat. So this is a pulse artifact over the T6O2, possibly over the right posterior head region. You can actually identify it by recording the EKG simultaneously. Slight change in the position of the electrode or the head could rectify this artifact. Movement artifacts, chewing, brushing, patting, coughing. So all these can cause artifacts, but you need to have a. So this is chewing artifacts. It's more prominent over the lateral leads, over the F7 T1 and F8 T2. So this is during video EEG what we recorded, and we can see the patient is having his meals, and along with that there's a eating artifact or a chewing artifact. So sometimes video at that time might help you to diagnose, okay, this looks like an artifact. So similar, same patient. Now this is a brushing artifact. We can see there is a blink, there is an artifact over the right lateral leads, F8 T2. Now this again is a brushing artifact. So a video sometimes might help you, okay, what exactly is this. And this is a patting artifact which was recorded during the EEG, video EEG for this patient. So if you don't have a video, you might think looks like a spiking wave discharges, but if you see this, so they are out of phase reversal. However, it is quite rhythmic and occurring almost 4 to 5 per second. Yeah. And then it is gradual build-up is there. It's increasing in amplitude and frequency. Then again it comes down. So a video at that time actually helped to see, okay, this is a patting by the mother on with the right hand. So it persists till the time she patted. Now this is a scratching artifact over the FZ, CZ, PZ, over the midline area. Then this is the cuff artifact which was seen. You have a lot of pharyngeal muscles, tongue movement also along with this, and masseter also, and temperature also getting activated. Technological artifact, that is electrode artifacts, which is electrode pop, contact, electrode movement, perspiration, and salt bridge phenomena. Now electrode artifacts, usually improper contact can cause, along with unprepared skin, or it's an underfill or an overfill of the electrode, and then you can have asymmetrical placement of the electrodes which can actually pick up some electrode artifacts. Now pop is usually a spontaneous discharge from the electrode. There is a potential between the skin and the electrode, a single spike discharge because of abrupt change in the impedance, and you have a steep rise and a steep fall. So it's a right angle upshoot and a shallow fall, or steep, it can have a steep fall also. We can see the right, left FP1, F3, C3, there is a sudden pop, so localized to a single channel possibly. There is no field as such in any of the other channels. And usually it's a mirror image. The up and down will actually have the image. Same image, no change in the background activity, limited to a single electrode. Now again if we see, T4, T6 is showing an artifact which is a mirror image out of phase reversal, very sharp uprise and a slow downfall, which is actually a mirror image. Similar in the other one also, C4, P4, P4, O2. Common electrode is P4, most likely it's a P4 electrode artifact. So FP1, F7, F7, T1, common is F7, likely to be an F7 electrode artifact. Now electrode movement. Sometimes electrode movement can produce sharp or slow waves of varying morphology and amplitude. It's a disorganized, not resemble any brain activity. So this is electrode movement. It's a bizarre movement happening of the electrodes, not any particular frequency, along with some movement artifacts or a muscle myogenic artifact from the patient. Now it is because of the high impedance which actually will cause falsely low amplitude or apparent low or apparent amplitude asymmetries. And then you can have loss of low frequency components of EEG activity which will cause these electrode movement artifacts. Now photoelectric response is seen over the frontal electrode with high impedance during photic stimulation. There is a photochemical reaction which can cause the spike-like transient with each photic flash. So here we see photic at 3 Hz, we can see left FP1, F7 showing photoelectric response. At 3 Hz, we can see 3 Hz response, which on increasing the photic to 4, it is called a 4 Hz response, and we increase to 10, it's a 10 Hz response. So this is time log to the photic stimulation. Then you have salt bridge phenomena. Smearing of electrodes placed between the two electrodes produce an unwanted connection between electrode forming a channel. So in this, if you see all of the leads are showing activity except for T6O2, which is showing a salt bridge phenomena. So they have joined and found one channel and it is almost isoelectric to each other and it's a flat line. Sweat artifact, perspiration artifacts are recorded as high amplitude, very slow potentials. That is where the need of high frequency, low frequency filter is required. You should not increase to more than 1. Keep it at 1 only, 2 minutes. Thank you. Patients resting on perspiration soaked pillows may display a voltage asymmetric by salt bridge that shorts between two electrodes contacting the perspiration. So this is a very slow wave which is occurring over the anterior head region. We see it's almost 0.5 Hertz. Now if you increase this low frequency to 2 or 3, this will be missed. So keep your low frequency filter to less than 1 so that you can pick up all these slow waves. This is again perspiration artifact, sweating artifact. We can see very, very slow waves, not more than 0.5 Hertz. So it is because of sodium chloride and lactic acid. It reacts with the metals of the electrodes, changes the electrode impedance, causes a huge slow baseline sways from 0.525 to 1 Hertz. Rectification, short time constant on low frequency filter should be done, and you can cool the patient, switch on the AC when the EEG is going on, drying the scalp with fan or alcohol and reducing the room temperature. Environmental artifacts, any electrode which is kept open, especially in ICUs, you have a lot of electrical lines going on, IV drip, ventilators, so many other doctors are moving around, phones are there, mobile phones, other phones. So everything can be picked up in this environmental artifact in ICU especially. Most common external artifact is 50 Hz artifact from the power line. It originates from unshielded electrical cables, electromagnetic fields produced by equipment like AC, fan, lights. So when the impedance of one of the active electrodes becomes significantly large compared to the ground of the amplifier, ground becomes an active, and then you can have this artifact coming into the picture on EEG. So it is because a high resistance electrode picks up all the types of artifact, appears a thick dirty line or crowded muscle activity. So in this we see a very dirty line coming on the EKG electrode. And when we change the settings, we can say this is 50 Hz artifact picked up in the EEG. Again, a 58 artifacts over CZ, PZ and P4O2. So when you switch on the notch filter, this usually will come down. So it is very important to switch on the notch filter. So again, P4O2 showing a 50 Hz artifact. Rectification, check the electrode impedance, check the cable line. Is more difficult to rectify in ICU because a lot of other things are going on. But grounding should be adequate. That is very, very important. In the ICU, keep EEG input cable far from the power cables. And sometimes the technician has to do a lot of work because artifact is coming in the EEG and you have to unplug one equipment after the another to find out where is the fault. Electrostatic artifacts, swaying electrical wires, it is because of those. Person moving around can cause, clothing of the artificial fabric can cause, and it is more when the humidity is low. So in this we can see an artifact coming on the patient is sleeping and then there is sudden movement which is causing a artifact in the frontal areas. Now this is again a mechanical ventilator artifact which is occurring at a periodic fashion, which is generalized synchronous with the mechanical ventilation. Now this is chest percussion artifact mimicking a seizure. You can see a gradual buildup is there and it is monomorphic like picture at a frequency of 3 to 4 Hz, gradually builds up to 5 to 6, and when the doctor stops it comes down. Dialysis artifact, patient was being dialyzed utilizing slow continuous ultrafiltration, that resulted in this artifact. Cell phone ringing artifact, we can see out of phase reversal at F4C4 and now telephone ring artifact which is more over the generalized, more over the T3, T4 regions and F3, C3, P4 regions. So artifacts can produce major problems in EEG interpretation. You have to be alert and aware. It's very, very important for artifact recognition and correction. 90% of the time, if the technician is good, he can pick up and correct it immediately. Last but not the least, keep the filter setting always between 1 to 70 Hz. Don't change it. So you can pick up all the artifacts and then you can see what is the cause of this artifact. Thank you.